So it was just interesting that to know uric acid or gout is a risk factor for erectile dysfunction. So would you recommend screening for hyperuricemia for any patient presenting with erectile dysfunction? That's question number one. Number two, what is the recommended startup dose for Avanafil? Would you start the patient with 200 right away, or you will just start up with 100 if failed, and after how many trials you will go for 200? And is the 50 milligram daily something recommended or not? These are the first two questions.
The first questions, we are producing our Italian guidelines on erectile dysfunction, almost finished, involved the most important society, the Italian society, not just the andrology society, so cardiology society, diabetology society, and so on. And essentially, we recommended, obviously with not a high level of evidence, but we recommended since the beginning to rule out possibility of increased uric acid in all patients seeking medical care for ED, for sure. Regarding the second questions, my suggestions, you know, Avanafil is available in the Italian market since more than 10 years, or almost 10 years. My suggestion is, since the drug is the one with the lowest incidence of side effect, to start with the highest dosage, and then if there are some side effects, you can reduce the dosage, but as you can see from the open label study, 52 weeks, only 0.4% require the dosage reduction. And finally, the last one, 50 milligrams daily, is just very interesting new paper published last month. So probably the daily administration, at least, is not recommended in the drug prescription notes. But as you know, the daily use of sildenafil, the daily use of vardenafil is the common clinical practice, and also possible combination of the daily use and on-demand use. So this could improve, especially in a selected patient, the outcomes, in my mind.
Dr. Jubani, thank you for the excellent presentation. I have two questions. One question is, we have a big population now of patients of the first generation PD5 that they're doing very well, whether they're taking tadalafil or vardenafil. Do you think that we should suggest for them to switch if they're doing well on their medication, or to stick to what's working? That's number one. The secondly, we all know from all data that erectile dysfunction is a window on a patient health, that you have to check in for diabetes, high uric acid, triglyceride. But also there is a lot of data that correcting high uric acid or correcting high triglyceride is better for the patient, but does not affect his sexual function. So correcting this comorbidities is good for the patient, but does not reflect on his sexual part. He still needs the medication for that. Do you have any data opposite to this?
So the first one question was related that people who correctly respond, so correctly
on whatever medication they are using now. Patients who come to the clinic, they are happy, they are coming to refill their medication, they are happy with whatever PD5 inhibitor. Do you think it's wise to change them to other medication or to continue on what they're taking?
Okay. So regarding the first question, if people are satisfied with the drugs, I have no good suggestion to change the drugs, considering a medical point of view. Obviously, if there are some side effects, even milder side effects, you can try the new drugs, which is the one with the lowest side effect. But if are satisfied, why we need to change? But we need to emphasize that many people, especially satisfied at the beginning, can drop. So maybe again, this kind of drug could help to try to save or to reduce the dropout on the first line PD5 inhibitors. Regarding the second point, probably the idea is to correct the associated morbidity at the beginning. Because if we look at the newly diagnosed type 2 diabetes, if we look at the people with hyperuricemia at the beginning, if we look at people with arterial hypertension at the beginning, probably the lifestyle modification, just weight loss, could improve just without medication, could improve erectile function per se, as well as life. Because there is a very famous paper from an Italian group, Katia Esposito and Dario Giuliani, published in JAMA long time ago, showing that weight loss per se, controlled trials, was able to improve more than 2-point score in rectal function domain. So just lifestyle modification at the beginning, obviously in more complicated issue, probably we can save the cardiovascular profile, but not to improve erectile function. This is the same for testosterone. Our suggestion is to treat testosterone in symptomatic men at the beginning. So obesity, but not complicated, because testosterone in this case can allow to improve muscle mass, to improve physical activity, and also erectile function. But in complicated men could be, as you said, good for life, but not for sex.
Professor Corona, very well informative talk. I want to ask about the physiological or cellular cause between HDL and testosterone. Why do we get this testosterone with the HDL? What is the actual physiological event happening? And my second question, can we combine PDE5 inhibitors with ICI prostaglandin just to give more potent erection?
So the first one, you mean the physiological, the underlying mechanism leading to hypogonadism in metabolic disease?
Well, what
or the physiological action of testosterone?
Physiological action.
Okay, the physiological action of testosterone. Essentially, testosterone can act at central levels. There are several areas involved in the control of erectile function expressed in androgens receptor. So testosterone can improve sexual desire, can improve the desire to do sex, so can act at central levels, but even at peripheral levels. Testosterone controls every pathway involved in the erectile function, can control the PDE5 gene expression and activity, control ROA kinase, control nitric oxide production, controls also the commitment of muscle cells. So in the presence of hypogonadism, there is a fibrosis, the penile fibrosis. So essentially, testosterone controls every steps of sexual function. Regarding the second point, a possible combination of PDE5 and PG1 is a common practice. Me too. I use the possible combination. Even at daily dosage and on-demand dosage, you can combine these two possibilities. There are no controlled data, but obviously they act in two different pathways, the one on cyclic GMP and the other one on cyclic MPC. So you can for sure combine the two kind of dosage for sure.
Thank you, Dr. Corona. 2 points. How does the second generation PDE5 inhibitors differ from the first generation? Second point is there a role for avanafil in treating LUTS symptoms like tadalafil?
Okay, regarding the first questions, probably the better PDE5 enzyme selectivity is the most important advantage of this kind of drugs of avanafil. So by being more selective for PDE5 is able to give a rapid onset of the action with the lowest incidence of side effect. Regarding the second questions was related to the role of avanafil in LUTS. There are no data, but for sure this is the effect on PDE5 in a reduction LUTS is an effect leading to essentially an inflammation within the prostate. So they works by reducing inflammation within the prostate, which is particular target of PDA5 enzyme. So for sure, I'm quite convinced, even if there are no placebo-controlled data, that avanafil can works in improving lower urinary tract symptoms.
Professor Giovanni, thank you very much for this very nice presentation. My question actually for our all benefit, on the real life daily basis, how would we perfectly recommend usage of avanafil for the daily use, for BRN use, and for combinations, and even salvaging non-responders in your daily practice?
Essentially, first of all, we need to clarify there is no indication from the brand. This is a daily clinical practice. As there is no indication to use daily sildenafil, there is no indication to use daily vardenafil. But it is common clinical practice, especially non-responder patient, to use daily PDA5 inhibitors and to add on PDA5 inhibitors during just before the sexual intercourse. So probably we need to better select the patient to discuss the couple. Obviously, if there is a couple, the use of combination and add-on can work better. If the patient used to have sex one time a month, it's quite difficult to select this kind of patients. But for sure, we need to discuss with the couple. We need to pay attention to the side effect, because obviously if there is a combination of side effects, the daily use and the add-on can increase the incidence of side effects. So we need to pay attention. We need to try our experience. I was not aware about the possibility to use avanafil daily. So this is the first paper emphasizing placebo-controlled, emphasizes this possibility. So this is a new possibility that we have in our pocket to treat these patients. So a new arrow in our pocket.
More in your presentation, in the comparison between SEP2 and SEP3 in the meta-analysis regarding the efficacy of 100 and 200 milligrams avanafil, the SEP2 odds ratio is lower than the SEP3, which is unlogic.
Yeah, this is our data coming from, not from my meta-analysis, but from the available studies. Probably the efficacy of the drugs, and especially the positive outcomes from the patients. So the great efficacy of the drugs was driven the patients to focus their outcomes on SEP3, so on the successful intercourse, rather than just, SEP2 is, do you have an erection sufficient for penetration? And SEP3, do you have a erection sufficient to have a successful sexual intercourse? So I will better focus my analysis on SEP3 rather than SEP2.
Thank you, Dr. Corona. I have two questions. One is for the physicians. I'm one of them who is avanafil naive. Would you tell me how to counsel the patient about drug and about food interaction, alcohol interaction, things like that? The second thing is avanafil has been here for 10, 12 years. Why it's so late to come on, internationally, even it was not very well represented in the major meetings. Can you give us a backstage story why avanafil is a late boomer?
Yeah, regarding the first one, the meal and the alcohol can also interact with avanafil absorption, even if at less extent when compared to other PDA5 inhibitors. But the only one PDA5 that cannot be affected by meals and by alcohol is tadalafil. Regarding the second question, probably this is a market problems, because you know sildenafil was launched in the US and then in Europe, then vardenafil was launched, then tadalafil was launched more or less at the same years, and were launched by a big company. Avanafil was marketed first of all in Korea. Maybe the problem is market in my mind. And you're right, why we reached this kind of drugs so late. But now we have it, so we must use it.
Okay, Professor, I have a question making use of a prominent endocrinologist. Sometimes we get the patients who have blown picture of hypogonadism. He's weak, he has poor libido, his muscle is weak, his mood is not right, he's not responding well to PD5. And you check his testosterone and it is low normal. It is still within the normal limit, but clinically he's manifesting with hypogonadism. Do you treat these patients even though if they have normal testosterone, low testosterone, or do you wait?
Yeah, we should emphasize that several factors. You should emphasize that testosterone, total testosterone, circulates in blood in 50% bound to a protein called sex hormone binding protein, in about 50%. And this binding is a very strong binding, preventing its fraction from its biological action. Only 2% of testosterone is free, and around 40% is bound with a weak binding to albumin. So common immunoassays are totally unreliable in measuring free testosterone. Conversely, we should take in account that several conditions can increase SHBG. So if we, especially in subjects with metabolic disease, there are several drugs can affect these conditions. There are, for example, drugs used for BPH that reduce the conversion of testosterone to DHT that can increase testosterone levels. So indeed, there is an increased testosterone levels, but the bioactive fraction is reduced. So my suggestion is to measure also SHBG, to go to the web, to calculate free testosterone. And even if testosterone levels are normal, total testosterone levels are normal, and as you said, there are symptoms, calculated free testosterone is pathological, meaning below 225, 220 picomolar per liter, you are allowed to treat this patient with testosterone.
I have two questions, actually. First question, I will take your expertise here for hypogonadism outside the scope of today's meeting. So what you will do for a patient with refractory hypogonadism not responding even to injectable testosterone? From time to time, we face something like these cases, and whatever you do, testosterone is still low, patient is symptomatic, even with injectable. So what you will do with this? Second question, can avanafil be used as a salvage therapy, as a second generation, for patients who failed the first generation?
Okay, the first questions. Essentially, testosterone is the gasoline, is the fuel of the machine. Without testosterone, there is no PDA5. So for sure, we should treat testosterone, all hypogonadal patients with testosterone, for sure, as a first-line therapy. But as I told you, in complicated patients, testosterone was not very good. So after the normalization of testosterone levels, we can add on PDA5 inhibitors or PG1, but we should stay in testosterone, because without testosterone, there is no PDA5, and PDA5 outcomes is worse. Regarding the second point, yes, it's true. All the data that I shown you in people with diabetes or in people with radical prostatectomy were derived from patients who failed PDA5 inhibitors. So for sure, we can use avanafil as a salvage therapy in people who were not responding to first generation of PDA5 inhibitors.
Would you prefer to use direct testosterone shot or use the aromatase inhibitor to raise the endogenous testosterone?
It depends on the couple and patient request. If there is a paternity request, you cannot use testosterone. So if the couple requires fertility, if the couple requires paternity, you can use not just aromatase inhibitors, maybe SERM, so that can increase testosterone levels without affecting fertility and just improving fertility, because they also works as agonist at mid-genitalia tract, increasing sperm quality and also increasing sperm expulsion. So I would prefer second option if, especially in a metabolic condition, if paternity, if fertility is required. Conversely, testosterone in all other cases.
First of all, thank you for your marvelous presentation. And in the slides you mentioned, you said that about 8 to 10 years tolerance may occur to the first generation of PDE5 inhibitors. So my question is, what are the criteria of the patient that can tolerate avanafil? And the second question, can we switch between the first and second generation if there is no response? Thanks.
Okay, for sure. I think every kind of patient with AD could be treated with the avanafil. There is no specific patients. And especially for sure, we must switch from all the patients who complain side effect for PDE5 inhibitors, and even in other patients, if the patient wants to try the new one, you can try. That's no problem. You know, the side effect is quite common with PDE5 inhibitors, especially at the beginning, especially with sildenafil, which is one of with the lowest selectivity. Back pain is frequently observed with tadalafil. We need also to pay attention on possible drug interaction. So the use of amiodarone is quite common in patients with cardiovascular disease, and we need to pay attention to vardenafil. There is no specific contraindication, but there is the increased risk of QT prolongation. So we need to pay attention. And I think we can use avanafil in each kind of patients.
Just one final question here before we go for dinner. This is from one of the audience. You answered that already. Is there any benefit from avanafil in cardiac patient who is on nitrate? Is it still precaution with nitrate, or is it safe?
No, again, there is absolutely contraindications. Even nitrates are absolutely contraindicated. Regarding the current information, we need at least 24 hours to start nitrates in people treated with short-acting PDE5 inhibitors. There are some preliminary data, but just preliminary data, showing that with avanafil, we can wait just 12 hours, but these are since preliminary data. And I'd like also to emphasize that the use of nitrates nowadays is quite uncommon, especially in the era of people which are able to arrive at the cardiology unit very soon after the onset of the symptoms, treated with coronary surgery. So the use of nitrates nowadays is quite uncommon when compared to 10 years ago or 20 years ago. We need to emphasize that nitrates can reduce the symptoms, but cannot reduce the cardiovascular mortality and morbidity. So we should start to give a good interaction with our cardiologists, and if possible, if the patient is under nitrates, we can ask to stop this kind of drug.
Thank you so much. I would like to, you have one question?
Just only one question. Is it effective in venous leak?
Sorry?
Is it effective in venous leak?
Venous link.
Yes.
But does venous link exist? In my mind, no.
Yes, it exists.
No, it's just in my mind, the venous link is more related to endothelial dysfunction of the corpora cavernosa, mainly, because you know the vast majority of the surgical outcomes were negative for venous linkage, So if you are asking if avanafil or any kind of other PD5 inhibitors can improve the cavernosal endothelial dysfunction, yes, probably yes.
Okay, so I would like to thank you for the great presentation, great answers to questions. I think you introduced the afanafil to the Saudi market in a very comprehensive and informative way. So thank you again for your presence, and I'll just give Arak Healthcare for the final closing remarks.